Greetings, CyberSight friends. It's a pleasure to be back here with another question and answer session. I particularly like these because we get to address what your specific concerns are, and it gives me a chance to see where everyone's coming from. The topics we'll cover today are going to be quite broad in terms of skill level. And so there will be some questions that may seem rather basic, but there will be some that are a little more advanced. And you can be quite certain that if one person has that question, probably 100 people have that question. So let me begin my screen share. As you can see, it's a beautiful day here in central Indiana, where I'm located, which is in the central portion of the United States. And let's dig right into our question and answer webinar. First of all, we had great turnout. We had over 1,000 people that pre-registered from 130 different countries with us today. And of those pre-registrations, I will probably prioritize the questions that were submitted in advance. So there were about 93 different questions. Most of them seem to be strabismus related, but there are some other topics as well. And we'll go through all of those. And I think I'm able to cover most of those in the 45 minutes or so that we have together. I'll also be monitoring the chat. So if you have questions, you can enter those into the live chat, and I will try to answer some of those as well. Just a little bit about me. So I am in the United States. I'm in the very central heartland portion of the United States in Indianapolis. I'm the comprehensive pediatric ophthalmologist, and I also do a lot of adult strabismus. I've been doing this for about 27 years. And during that time, I've done more than 10,000 surgeries, and I've been an Orbis volunteer for most of that time. And for the past 12 years, some of you may know me as the medical advisor to Orbis CyberSight. So as a volunteer, I've had the chance to operate in more than 20 different countries around the world. So I have a good feel for what general skill sets are and what general resources are in most of the places that we work. All right, like I said, I'll try to cover everything, and I'll give priority to those of you that sent questions in advance. Because most of this is strabismus related, I thought I'd start off with a couple of non-strabismus questions that we had. But first, I want to direct you towards this. They're going over the questions. It appears to me that there might be a need for being aware of this pediatric ophthalmology course that we have on CyberSight. Now, if you go to the library and if you specifically go to courses, you can find that there is a very comprehensive fundamentals of pediatric ophthalmology and strabismus course. And it's broken down into 5 or 6 modules, one of which is basic strabismus. And then there's another module on advanced strabismus. But it also has modules on pediatric cataract, pediatric glaucoma, including how to do those procedures step by step. And there's also a brief section on retinoblastoma. So it's a rather lengthy module, but once you take the pretest, you can go through and look at different sections. And so if there's anything that you want to follow up with after this seminar, take a look there, because most of this is included there since I created that module, and it's at least most of it. All right, we'll dig right into our first question. This is an interesting question, I thought. And the question was when to operate for pupillary membranes. And people often get worked up about these. I find that most of the time, the vast majority of the time, these do not require surgery. So how do you know whether or not to intervene? Because there certainly are some risks when you intervene. You could create a cataract. So when you're looking at these kids, of course, if they're old enough to be able to do some fixation behavior and tracking, you want to cover the other eye and see how they react and how they're able to track with this eye. Can you see the red reflex? All right. Now, the pupil can be small, but not too small, and you might still lose the red reflex. So, but it's reassuring if you can see it. When the pupil's dilated, can you refract through it? When the pupil's not dilated, can you refract through it? So some of that's going to guide you. And then can you see the fundus? At any point in time, and it doesn't really matter if, like in this case, the pupils being decentered a little bit. The centration of the pupil doesn't matter. What matters is that pupillary opening large enough? And generally, the pinhole test is about, I think, 1.5 millimeters on an occluder. And so generally, if you have a pupil size that's 1.5 millimeters or larger, you're going to be okay. But otherwise, if you feel like you're not able to meet these criteria, then stripping that pupillary membrane out of there carefully may be indicated. Another question came about scleral fixated lenses. And I have recently stopped doing cataract surgery, but I did pediatric cataract surgery for a long time. And I have experience with both of these. So the answer is yes. And most commonly, this comes up with Marfan syndrome or just idiopathic familial lens subluxation. And for a long time, I used this lens on the left side of the screen, which is the Alcon CZ70. And it's particularly nice because it has eyelets in the haptics so that you can really be certain of your lens centration and rotation. Now, the only downside to this lens is that it does involve passing a suture through the sclera, and once you have that suture, you want to be able to bury that. There are published techniques for how to bury the knot and guidelines on what size suture to use. But that lens works quite well. I think I would be more hesitant to try that technique with a lens that didn't have the holes in the haptics, but I realize that sometimes those are not available. In the more recent years, I've switched to the lens that you see on the right side, which is the Artisan Claw. And I find that to be probably much preferable. And once in a while, we've had some issues with one of the haptics coming loose. It's relatively easy to reposition it. And this lens seems to be very well tolerated and give great results. And I think the long-term safety of it is probably greater since you don't have that suture going through the sclera. And just remember that a sutured intraocular lens, at some point, that nylon or Prolene suture is going to degrade and it's probably going to come loose. So now, the Artisan does require a PI. As you can see, it's been done superiorly there, so you don't get pupillary block. But otherwise, these would be the two lenses that, in general, I would use, and it is safe to do that. Now, of course, I think the big question with subluxated lenses is when do you intervene? And you don't want to intervene too early because these are not ideal options. These kind of aphakic lenses. So as long as possible, I try to manage them with careful refraction and correcting their astigmatism and induced myopia. And sometimes you can even treat them as an aphakic patient. If the lens is so subluxated that it starts to get out of the way, you can refract them through the aphakic portion of the eye and maybe even constrict their pupil so that the lens edge is out of the way. So you could treat them with aphakic spectacles as well. And there's certainly nothing wrong with that. All right. And then, like I said, most of the questions, well over 90%, were strabismus related. And so there's a gamut of things that we'll talk about here. And I thought I'd just start in an age-based progression here and talk about congenital esotropia. And one of the questions I had was posed with is, can we identify strabismus in a newborn? Well, you can, but in some ways, you don't really care too much about it because it's going to change. So I think screening for red reflex in a newborn is great. I think screening for strabismus is probably not a big deal. Now, this has been looked at. People have gone around to NICUs. One of my senior partners did this project 30 years ago where they went and examined babies in the NICU, and the most common alignment was exotropia, and then that kind of resolves. And all of us get sent kids that are a few months old that are having intermittent esotropia, and then most of the time we're just not really doing anything with that. Even if someone has a manifest esotropia, if they're 3 or 4 months old, you're probably not going to do a whole lot. So in general, we suggest that people refer patients to us if their alignment has not normalized by 4 to 6 months of age. And then we're generally going to be monitoring them for a while. They don't usually have fixation preferences in amblyopia, but if you detect that, then during this first year of life, managing that is probably the main priority. Now, there was another question about how can we differentiate whether strabismus is congenital or acquired when these patients come at a later date. Well, there are some hallmarks of congenital esotropia, and there are lots of different names. Sometimes we call this congenital esotropia. The more preferred name recently is essential infantile esotropia. And there are some hallmarks of this. Characteristics are that it's usually a large angle like you see in the photograph here. By definition, it needs to be present by 6 months of age. They typically are going to have pretty mild, minimal hyperopia. So to be a pure essential infantile esotropia, the hyperopia is typically going to be less than 3 diopters. You want to see full motility, no evidence that it's a 6 nerve palsy or a Duane syndrome. And some of the characteristics when you see these patients later are going to be the presence of latent nystagmus or OKN nystagmus asymmetry, and then the presence of inferior oblique overaction, as well as dissociated vertical deviation or DVD. These don't guarantee when you see a 6-year-old that it was a congenital condition, but these are the things that are generally suggestive of congenital strabismus. Now, the question is, how do you manage infantile esotropia and what is the optimal timing of surgery? Well, in general, it's not a refractive problem. But if you have a 1-year-old and they have some significant hyperopia, +4 or +5, it's always worth trying them in their cycloplegic refraction to see if that has any impact. Now, the truth is, most of the times we try that, and in these infants, it doesn't make a whole lot of difference. But I think you're obligated to see what, if any, component of this is refractive. Part-time occlusion, if there's a fixation preference or suspected amblyopia, obviously you can't measure the vision, so you're looking at fixation behavior. And if they do have a fixation preference, you want to perform some part-time patching to try and equalize that. Because these patients usually have very minimal hyperopia, they are not typically atropine penalization candidates because you just don't get that much blur induced when someone's a +2 or +250. So usually but the good news is that usually patients this young, they don't have a great pincher reflex, so it's hard for them to remove a patch. So they're usually pretty easy to patch. A related question here was, is there an age when you'd rather not perform strabismus surgery in children or adults? Well, first of all, for adults, no, I don't really have an age for adult surgeries. I will operate on people that are 90+ years old if that's what they need. And as long as someone's healthy, the general anesthetics are safe and these procedures are pretty short. Older adults can also easily be done under local anesthetic if need be. They seem to have much lower amounts of pain from strabismus surgery than younger people do. But in terms of this population, this infantile esotropia population, there's just not a big hurry to operate on these kids. A few decades ago, there was a push to do very early surgery. And I know in our institution, we were operating on kids as young as 6 months for this. And then we followed up on them for the next 10 years. And it just turned out that doing the surgery at 6 months of age was technically more difficult. Things are very small. It's a small space. The surgeries are very difficult in these really young kids. And it turns out there's probably not a huge advantage to that in terms of obtaining stable alignment, stereopsis, fusion, preventing DVD. There might be some mild benefits, but it's just that it's pretty mild. So in general, we're going to wait until these kids are a little bit older. I like to target around a year of age or just after. But there are certainly many places, Europe and other places, where it's more traditional to operate on these kids at 2 or 3 years of age. Now, I'm aware of Malcolm Ng has a paper that did show some benefits to operating before 2 years of age versus after 2 years of age. But again, the benefits are on the small side, and I don't think you have to have an absolute. I do think that the critical thing here, especially if you're in a limited resource setting, is when is the anesthesia safe? You know, if your anesthesia service cannot safely put a 1-year-old to sleep for surgery, then you wait. It's just not that big of a deal. Another advantage that comes up maybe in terms of later surgery is that if you're operating when they're 2 or 3 years of age, you know, a lot of times by then the DVD has started to develop. So if you start to see that, if they've got DVD and inferior oblique overaction, then at this point you have the option of doing kind of both the ET surgery and the DVD surgery at the same time, versus if you operate at a year of age, you're fixing the ET usually, and then several years later, you're looking at a second surgery to fix the DVD. So pluses and minuses to both. The bottom line is you do what's safe because the visual benefits are going to be limited. Several questions came up about glasses and strabismus. One, can squint be corrected by spectacles? How to prescribe glasses for squint patients? How to manage esotropia with hyperopia? Hypermetropic correction. Is surgical correction more convenient than prescribing glasses? And what is the treatment of crossed eyes in young patients and can be cured with glasses? Well, let me address a couple things here. One of them being the second to the bottom one here. Is surgical correction more convenient than prescribing glasses? Maybe. I mean, there are a lot of times when people don't want glasses, they don't want their kids in glasses, they have trouble getting glasses and keeping them repaired. But the bottom line is, especially if you're talking about refractive esotropia, you got to put them in glasses. That's the treatment. If you operate for to align or refractive esotrope so they don't need glasses, then you're going to end up with a consecutive exotropia over time. So we really need to correct the hyperopia when that is a factor. There's just no way around it. Before I move on, another question came up about prism. And in kids, I will almost never use any prism correction because they're very good at suppressing. They generally don't need it. And generally their angles of strabismus are quite large. You just, from a practical standpoint, how much prism can you put in glasses and have people tolerate? Well, it's that number's around 8 to 10 prism diopters. Now, I certainly see people wearing more than that, but it doesn't work very well. You can't see well, there's distortion, they don't like it, it's heavy. So practical standpoint, prism in glasses is limited to smaller numbers, around 8 to 10 or less prism diopters. So when do I use prism? Well, I will use it in young children who are actually diplopic. And you might most frequently see that if someone gets a consecutive ESO deviation after surgery for exotropia. And we'll frequently use a temporary prism like a Fresnel, but sometimes you have to go with a permanent prism if they don't kind of settle down over time. So that's maybe the one most common time in kids that I use prism. My results for things like convergence insufficiency are, I think, generally kind of disappointing, but once in a while there's an application there. For adults, your applications for prism are much greater because they're generally more sensitive to diplopia. But again, just keeping in mind what's practical. Don't give someone 20 prism diopters of prism. It's just not going to work. Those people really need surgery if their deviation is that large. And how do I do prism? I'll just mention this. What I like to do with adults in particular is let them hold the prism, give them a prism bar, and have them subjectively move it up and down. And that way you can find what is going to be most comfortable and most clear. And I'll generally look at that and I try to give them the least amount of prism that it takes to resolve their symptoms. So keep prism to a minimum, get some subjective input from the patient before you dispense that. All right, but there's more to talk about here with glasses and strabismus. But as we lead into that, the question came up, what are the most common causes of strabismus? Well, that's almost impossible to answer because it's such a huge list of all the other factors that go into it. But I think there's no question the number one factor is hereditary. If you see a kid with refractive ET, it's so common that you see a parent with refractive ET. And same thing with exotropia, that tends to run in families as well. And then we have all these other modifying factors. But I think, so most of the time this stuff is unknown. It's idiopathic, there's a familial tendency, but what are the other factors? It's hard to say. But what are the most common types of strabismus? So I think that's what we should talk about, and how do you handle these most common types? Because as you go through your clinic day, the vast bulk of the patients that you see for strabismus, at least in children, are these two categories. It's going to be the accommodative esotropes, and it's going to be the intermittent exotropias. And, there's a lot of variation as you go around the world as to what's more common, but by and large, these are the two big things that we deal with pediatric strabismus. Now, the accommodative, or we call it accommodative or refractive esotropia, onset is usually around 2 to 3 years of age, right? So these kids don't usually present at 6 months of age. 2 to 3 years is quite common, but they can be younger. You will sometimes see a 1-year-old that is a refractive ET patient. But true congenital or infantile esotropia, it's really a lot less common than we think. And there are various estimates of this, but it's just not that common that you see a pure infantile esotrope. But those characteristics again are that those tend to be manifest, low hyperopia, large angles, and there's just not that variability that you see with the accommodative ETs. The intermittent exotropia, what we call basic type exotropia, or it's frequently a little bit of a divergence excess, where the distance measurement is greater than the near measurement. Again, onset is typically in that same age group, 2 to 3 years, but they can be younger. And like congenital esotropia, true congenital XTs, decidedly uncommon. You see it, but it's even less common than congenital ET. And again, these kids are manifest XTs. These are not intermittent, and they are typically non-refractive. And just like congenital ET, they are typically surgical issues rather than refractive issues. Accommodative refractive ET. All right, so this is the bread and butter. You've got to know how to handle this. These are kids that have significant hyperopia, or they can have anisometropia, which is tipping them over to cross. The treatment for this, you got to be able to do a cycloplegic refraction. You got to put them into the full plus, and you're trying to relax them as much as possible and get those eyes straight. I will only reduce the plus if it doesn't work out. So if they have esotropia like this child does, they're getting the full plus. They come back and they won't wear the glasses, or having other problems, or maybe you get a XT in the glasses, then I will reduce it. Now, for a straight-eyed kid with hyperopia, we don't typically put them in the full plus, right? We'll reduce it by a half a diopter, or 1 diopter, or 2 diopters, so that the straight-eyed kid can do some normal accommodation. But if they have esotropia that's manifesting like this, you put them in the full plus. So I'll give them the full plus, and then I'll recheck their alignment in a few weeks. I usually see them back a month or two later. And at that point in time, I'll decide if they need amblyopia treatment. Now, if they come back and they're ortho at distance, but they're ET at near, that's still not necessarily a surgery patient. The next step there is you put them in the bifocal, try to relax their alignment at near, and see if you can nurse them along. If they're not ortho, then if these patients have manifest ET at distance and near, then you're operating for that leftover amount of deviation. Okay, so we're measuring for their alignment in the glasses. The intermittent XTs. Question came about. It's such a popular category. The question came about: do you avoid surgery for intermittent XT? And then there was a question about refractive error management for XT. How to treat exotropia in an emmetropic eye. How to manage residual XT following LR recession. So, do I avoid surgery in the intermittent XTs? No, but I do try to time it. First step with these kids, when you see an intermittent XT that's 2 or 3 years old, of course, you want to know what their refractive error is. If they have any significant myopia or significant astigmatism, then we want to correct that. Because if they're blurred, then that's similar to being occluded, and they're going to manifest their deviation more frequently. So when I see these kids, I'll prescribe the full minus correction and give them the least amount of plus. Now, sometimes these kids are surprising, and that they'll actually be high hyperopes, and they're just so blurred that they kind of give up their accommodation, and they'll actually be XT even though they're a high hyperope. And in that case, you do want to correct most of their hyperopia so that they're doing more normal amounts of accommodation, and then see what their alignment is. There's always the topic of over minusing for intermittent XT, and I do over minus some kids, but I'm not a huge fan of it. For me, it's typically something that's a temporary move until someone has surgery or until they're ready for surgery, or in those cases where the families are trying to avoid surgery. But I don't find it to be a real reasonable long-term solution. Obviously, a younger kid can tolerate over minusing and accommodation. However, as they get older, they're able to accommodate less well. So it gets to be diminishing returns as they get older. When you over minus, you're finding out whatever their refractive area is, and then you're giving them typically another -1 or -2 diopters of myopic correction. That stimulates accommodation and convergence. So that's how you're trying to just improve their control. Some people will even over minus by larger amounts, up to 4 diopters. I tend not to do that. I think that's a big accommodative demand at that point. So this goes back to the one of the questions I mentioned earlier. How do you treat an exotropia in an emmetropic eye? So an emmetropic eye, we've got a refractive error of 0. And what I would do with a patient like this, if we're just trying to control this exotropia or intermittent exotropia, trial lenses, so put some -1s, some -2, some -3 in front of them, and then remeasure them. If stimulating that accommodation by giving them minus lenses instead of no glasses, if that helps to improve their control, then I would feel comfortable dispensing that in glasses and monitoring them. But again, it's probably going to be a temporary move here. Yeah, for me, the big question is not do you intervene in XT, but when do you intervene? And it's not so much an age-dependent question, although there are some common ages. It's really more dependent on their level of control. You don't want to do it too early, and you don't want to do it too late. What's too early? Well, really on an intermittent XT, you don't want to operate too early, because if you get someone who's overcorrected after their surgery and it's a 2-year-old or a 3-year-old, well, now you've converted a benign intermittent exotropia that just looks different. You've converted that to a constant esotropic deviation, which creates diplopia and stimulates suppression. And now you're dealing with an amblyopic eye that you have to patch. So, and also, if you operate too early, you're going to be less confident in your deviations and your measurements. And it seems like a lot of these measurements will build up over time. So they might be 20 prism diopters of intermittent XT at age 1 or 2, but then by 4, that deviation is more like 30 or 35. And so by waiting a little bit, it helps you avoid the risk of amblyopia with a consecutive ESO deviation. And it also allows you to monitor them and do a surgery for a maximum deviation, trying to minimize reoperation. Because we all know that intermittent XT has a high rate of undercorrection and it has a high rate of reoperation. So surgeries for residual XT can be as frequent as greater than 50%. Now, there's a difference between these kind of intermittent XTs that start at 2 or 3 years of age versus those that are infantile congenital. These kids that are XT from birth and they're never straight, I pretty much handle those like congenital ETs. And so I will not do the surgery immediately, but once it's safe from an anesthetic standpoint and it seems that the measurements are predictable, I'm usually operating at around a year of age. There are some reports that congenital XTs have a higher rate of neurologic abnormalities, but I would not automatically do an MRI in this age group unless there was some other sign that something was wrong. All right. So for me, I'm usually monitoring these kids a couple times a year or more, and then we're typically planning surgery as they get ready for school age, so around 4 or 5 years of age. I think that's enough time to get some vision development, decrease the risk of amblyopia if you have an overcorrection. And from a social standpoint, these kids aren't usually having problems with other children until around age 5 or so. And that's when you start to see that becomes a factor. You do want to operate before the near control is lost. So you don't want these kids to be manifest all the time. Some people will lose stereopsis permanently once they lose that intermittency. So that's a little too late. But letting them decompensate a little bit is kind of ideal and just prior to school age. When I talk to parents and try to get them to wait a little bit, kind of describing this as you have a piece of fruit that's ripening, and you don't want to eat that fruit too early or it's not going to be good, and you don't want to do it too late or it's not going to be good. And so you're trying to time it just right to get the best result and in the safest manner possible relative to the anesthesia and the amblyopia. All right, surgical approach. Question came about surgical target for intermittent exotropia. Well, the surgical target is typically going to be the larger deviation on alternate cover testing. And that larger deviation is typically going to be the distance deviation. So this is why strabismus surgeons have 20-foot, 6-meter lanes, is because we want to get that distance fixation and that distance measurement. So we're operating for the maximum distance deviation typically. Now, what is the procedure of choice? Do you do a bilateral lateral rectus recession? Or do you do a unilateral recess resect? Well, it probably doesn't matter. I think a lot of this is going to be surgeon and patient preference. There was a pediatric study about 5 years ago, and there were some small advantages to R&R on one eye versus a BLR recess, but at the end of the day, that was not really significant. So I think you can pick and choose what you like. Now, I will use both of them, and I'll have some preference for one or another. If For instance, if there's a really large disparity between the near and distance deviation, such as this example I have here, where they're 40 xt at distance and 20 xt at near, I'll probably be inclined to do lateral rectus recessions for that. And then also when you have a need to do an upshift or downshift for a pattern, then the lateral rectus recessions allow you to do that easily. However, when the distance and near deviations are pretty similar, or when you have these large deviations, 40 and 50 prism diopters, I find that a unilateral resect procedure allows me to get that larger amount of correction more easily without having to do such a large amount that you cripple the lateral rectus function. Question about what tables are best for squint outcomes. Well, I don't know that any one table has been proven to be superior. There are many versions out there from very well-respected people. Most of them are quite similar. I think where I tend to see that there's a difference in the different tables is when you get into the larger deviations, which are less predictable. Some of the tables don't cover those quite as well. The measurements that the surgery dose table that I tend to use is this one, which is based on Marshall Park's recommendations, and it's been modified over the years. But again, it doesn't really address very large deviations. So the big thing is it's very easy to look these tables up, and you are typically, when you're looking at the deviations and picking out numbers, you're trying to do the maximum deviation in general. And you want to try and avoid estimation techniques. And we had some questions about how do you measure deviations? All right, now that seems like a pretty basic question. And that's the kind of stuff that's covered in the strabismus module. But how do you measure the deviation? What you really need to be able to do a prism and cover test. So that means you need a fixation target for both up close and in the distance, and you need to be able to do alternate cover testing. So when you do alternate cover testing, the prism is in front of the eye and the occluder is going back and forth. And that is going to uncover the maximum deviation. All right, so that's the tropia plus the phoria component. And that's typically what you want to use for most of our strabismus surgeries. There are always some exceptions. Now, if you're not comfortable doing prism and cover test, there is a simulator that's available. This is at the American Academy of Ophthalmology's website. There's a Pediatric Ophthalmology Education Center. And this simulator allows you to simulate practice doing cover testing. And it also allows you to measure vertical deviations, and it allows you to practice with simultaneous prism and cover. So for a very basic introduction, that's a nice thing to experiment with. Question came up, the difference between the Krimsky and the modified Krimsky, and which one is better? Well, there's probably not a whole lot of difference, but the differences are on the left side, the Krimsky test, as originally described, involved putting the prism over the deviated eye, and then looking at the corneal light reflex as you hold a torch or a muscle light and trying to center that reflex, and then that would be the prism deviation. That was modified to the modified Krimsky, where you're putting the prism over the straight eye, the normal eye, and you change the prism until the deviated eye appears to center. Probably the only major advantage over that is that cosmetically, you can see the deviated eye and get an assessment of where it looks good. And then also if the deviated eye has any kind of corneal irregularities, it's a little easier to judge the centration with the modified technique. But ultimately, they're both estimation techniques. There's probably not a big difference. They are not preferred. And about the only time I will use these is when I am operating on an eye that doesn't see well, and you just don't have any way to do fixation and alternate cover. You really want to be able to do cover testing to get an accurate measurement. And here's an example of the table screenshot that I showed you earlier. And this is like I said, these are just rough guidelines. You always have to modify this. One of the questions came up about what do you do for residual strabismus? And if someone has ET surgery and then there's still ET and I'm going to the laterals, I will just say that I will back off on the resection component for the second surgery. So when you're resecting against a muscle that's already been weakened with a recession, I think you want to be a little cautious and back off by a half or 1 millimeter and do just a little bit less surgery rather than what's exactly on the tables. Now, a question came up, do you ever do single muscle surgery? And the answer is yes. Here you can see the very first column on the left side for small deviations. So 15 prism diopters, it's probably equivalent whether you do 2 3 millimeter recessions or a single 6 millimeter recession. For me, doing 2 3 millimeter bilateral medial rectus recession just kind of seems odd, and I will usually do the single muscle recession in this case. And you'll notice that there's really not a table for single muscle resections. A lot of people have looked at this. You will find tables or guidelines out there. I've looked at this in my own practice, and I found that the single muscle resections were pretty variable. And so while I will use that as a follow-up surgery for some people, it is for primary surgery, for a horizontal deviation, I would not say that I do that very often. And then here's the same table for XT measurements. And so I know you can screenshot these, but again, if you go to the strabismus course that I mentioned, these tables are all there. And I believe that actually the one that I showed you that was a document, I think that is downloadable as a PDF from that course. And again, you can see same question about single muscle surgery for small angle XTs, 15 to 17 prism diopters. Then you can do a single large lateral rectus recession. All right. For vertical deviations, guidelines are a little more straightforward. In general, resecting or recessing 1 millimeter per 3 prism diopters is about what we typically do. Just keep in mind that restrictive cases like thyroid, you'll tend to get a higher change per unit of recession. So you might get more of a 4 diopter correction per millimeter. Is it better to operate on one or both eyes? It probably doesn't make much difference. You know, we spend a lot of time talking to people about is the surgery going to be on the left side or the right side, or is it going to be bilateral? And, you know, ultimately it probably doesn't make any difference. And so I always listen to the family input and see what their feelings are. And I'm pretty flexible on this. In some ways, I do prefer unilateral surgery. Again, you know, for large deviations, a unilateral resect, I think you can get more correction. Secondly, if you do a unilateral resect and you don't get enough correction, then it feels more clean to go to the other eye and do another resect or single muscle, and it seems more predictable. What I really don't like is when I've done either medial rectus recessions or lateral rectus recessions, and I end up with this large residual, and now I'm looking at bilateral rectus resections or plications. You just too commonly you end up with a little bit of restriction or overcorrection with that, and I just kind of try to avoid that when I can. A question came up about what are the risks of squint surgery. We kind of take it for granted that there aren't really any risks. And in general, that's true, you know. Can you get infection, bleeding? Yeah, you can, but those things are pretty uncommon. Need for additional surgery? No, that's a big one. And I routinely tell people, even with the most straightforward case, that there's a 20% chance that they need a reoperation. But we know with some of the conditions, the reoperation rate is going to be much higher, like 50%. So you do need to make sure that people are aware of that. Loss of vision, fortunately, is quite rare. Now, the variable estimates for endophthalmitis, 1 in 20,000 to half a million, quarter of a million. and then anterior segment ischemia. These are about the only two ways you can really get loss of vision. And in 27 years, I've seen 2 cases of endophthalmitis and 1 case of anterior segment ischemia. And all of those did poorly. But fortunately, these are pretty rare. How do you get endophthalmitis from strabismus surgery? Well, typically it's going to be something that starts off as a conjunctivitis, and then you get some abscess formation around the suture, and it's able to erode into that scleral tunnel and then erode to the scleral wall. The 2 times that I've seen it, I think that is what has happened, and it just didn't get caught early enough. Diplopia, people make a big deal about diplopia and counseling people not to have strabismus surgery, particularly adults. And I got to tell you that, most of these adults have diplopia to start with. So they're generally just interested in getting their diplopia reduced or their eyes cosmetically aligned. And I don't think I've ever had to reverse someone's surgery because of diplopia after surgery. So I just don't take that into. We like to assess for it and counsel people, but I think from a practical standpoint, it's actually pretty uncommon that you create diplopia that people didn't have. And a related question came up in strabismus surgery: how do you predict diplopia? All right. Well, kids, I don't worry about it too much. Most of them adapt, and I think it's more, as long as you get accurate measurements, most of them will be okay. It's very rare that they have persistent postoperative diplopia that's a problem. If they do, sometimes prism is needed or revising the surgery. In adults, I do try to see subjectively if they can fuse with a correcting prism. And it's not make or break for me. I feel more assured and can be more confident in talking to them if they're able to fuse. But there are definitely times when I can't get them to fuse, and we proceed with the surgery, and they usually do fine anyway. But you want to be cautious about that. Angle kappa, do you take that into effect? So these people, the optical axis and cosmetic axis don't align. Well, I think you have to, when you have a significant angle kappa, you do have to be aware of it, and you have to decide, are you going for a functional result where you want the optical axis to line up, which is usually what you're going to want to do for kids in particular, or you're looking for a cosmetic result. And I see this in adults where, I don't know, they've got a dragged fovea from childhood ROP or something. And really what they want is they want their eyes to cosmetically be aligned more than they want the optical axis to be aligned. So talking to the patient, figuring out what the goals are, and then you decide if the angle kappa is a factor. A couple questions about Duane syndrome, and doing consults on CyberSight for a long time, almost 2,000 of them. I will tell you that Duane syndrome is one of the #1 topics for consultation. So it is a big deal. This first question was about Duane syndrome type 1. How do you operate for it? Well, usually, why are you doing surgery for Duane syndrome? Usually because they've got a head turn from the eye being kind of restricted, esotropic. Or they've got manifest esotropia in the primary position. And you can usually safely and predictably just do a moderate recession on the Duane's side medial rectus. And it'll be tight, but it seems like about a 5mm recession will usually correct your head posture and align the eye. The other way to do this is to do a bilateral medial rectus recession, but do it somewhat asymmetrically. So while the Duane side medial rectus might get recessed 5mm where the muscle's tight, on the normal contralateral eye, you can do a large recession of that medial rectus. And by large, I mean 7mm or so. Now, what does that do? Well, if I have Duane syndrome and my left eye won't go out, if I do a big recession on the contralateral medial rectus, well, now that eye doesn't go in quite as easily or quite as well. And so you can get a little better matching of their diplopia free field. The second advantage is if I've done a big weakening on the non-Duane's medial rectus, Now that's going to drive a lot of input to the Duane side lateral rectus. So if there's any abduction ability, you can help drive that range of motion to be better. And so those are kind of my two typical approaches to Duane syndrome type 1. And then a question came up about Duane syndrome type 2 or XT Duane's, and specifically with upshoots. Sometimes you can have a type 2 that's not exotropic at all. It's mostly the upshoot that's a problem. Other times you've got the XT plus the upshoot. If there's exotropia, you want to recess the lateral rectus. If there's no exotropia, but there is an upshoot, or if there's XT plus an upshoot, then splitting that lateral rectus is helpful. These eyes look like they'll kind of look like inferior oblique overaction when you have these Duane's upshoots, but that's not it. It's the fact that that lateral rectus is tight, and as the eye tries to adduct in towards the nose, the equator of the globe is coming right up against that tight lateral rectus, and it's either going to roll above it or it's going to roll below it. And so you can get upshoots and downshoots because of that contact with the tight lateral rectus at the equator. If you split it, now you've spread out the width of the lateral rectus, and it diminishes that upshoot downshoot. So splitting the lateral rectus, possibly combining that with recession, is what I will do in these cases. How do you split it? Well, before you disinsert the muscle, before you put a suture in the muscle, just take a Stevens hook and you slide it along the length of the muscle fibers, kind of as far back as you can go with a small hook like a Stevens tenotomy hook. And then you put suture, 2 double arm 6-ovical sutures, 1 in each half of that muscle, and then you spread it out when you reattach it, so it's roughly the width of the original insertion. And that's how you do a wide split. And again, that's covered in the strabismus modules that I referenced that are in the cyberpsych courses section of the library. All right, this is an interesting question. This came up. What do you do with a new onset non-refractive esotropia in a 5-year-old? And we see this not infrequently, and it's always disturbing for people. Kid is normal, no family history of strabismus. One day the kid just has esotropia. And I see these kids, they get sent for MRIs, they get lumbar punctures, they get all this stuff done, and they finally get sent to us. And, 99% of the time, these kids are just normal, and we don't know why it starts. Is it post-viral? You never really quite fully know. Now, how do I handle these? Well, it kind of depends on the timeline. If it's been there, if it came on acute and it's been there 2 years and they have no refractive error, well, that's different than someone that's just come on about 2 months. If it's been there 2 years, then just from time that it's probably not a tumor or something dramatic like that. All right, it would have changed. So what now, if it's new though, if they were normal 2 months ago and now they're not, then that's probably going to raise your concern level a little bit, and you're going to be more likely to do neuroimaging and preferably an MRI, limit the radiation exposure in these cases. When I see these kids, I want to make sure that their motility is normal, that there's no evidence of a 6 nerve palsy. All right. If you have evidence of a 6 nerve palsy in a kid, that buys neuroimaging in my book. And then you want us to do a rough screening of the other cranial nerves and make sure that nothing seems out of ordinary. And then you want to do a dilated exam and make sure they don't have papilledema. Now, if all those things check out, then I think that the neuroimaging becomes optional. And you kind of have to listen to the family's concerns, and you kind of have to see how much time has gone by and make a decision as to what you're comfortable with. In 27 years, I don't think I've ever seen a 100% healthy, normal kid with acute onset ET where I found anything dramatic on the imaging. So You want to be careful with these kids, but usually the workup is going to be negative, fortunately. Getting close to the end here, I think I have a couple more slides perhaps. One of the questions that came in was about Faden suture, and when do you use the Faden suture or thread suture, as it was referred to? Well, what is a Faden? A Faden involves, if you look at this image over here on the left side of the screen, you've got a normal, let's just say this is a medial rectus in frame A. In frame B here in the middle, you can see a suture's been placed, and that suture is not the entire width of the muscle, but basically it's a non-absorbable suture that is placed through the borders of the muscle. So the 1/3 muscle width to either side of the muscle, and then you tack that to the sclera using a partial thickness scleral bite, and so now you've fixated the muscle to the sclera about, usually it's at the equator or slightly behind the equator, so maybe in the ballpark of 8 millimeters back or so, or 10 millimeters back. You kind of got to see where, in practice, you're trying to do it more or less as far back as you can get it. And then what happens is, with distance fixation, it doesn't really change the function of the muscle. But now when someone tries to converge and look at something up near, the new effective insertion of the muscle is where that Faden suture is. So it allows you to get weakening of function only in the field of action of that muscle. So in an esotropic patient with a high ACA ratio, they're pretty straight at the distance, but then they get this huge ET at near. A Faden suture can be useful to decrease that near deviation. Now, you don't want to do this in a 5-year-old, a 6-year-old. You want to, if you're going to need a Faden suture for a high ACA ratio, you want to let that kid's normal hyperopia and accommodative convergence response run its natural course. So I find this to be useful either in adults or older teenagers who have not outgrown the need for a bifocal for a high ACA ratio. So not in any big hurry to do this. It's difficult to reverse it once you do it. But this is a way to get people out of bifocals if they don't improve over time. The other time that I'll use this is the orbital floor fractures. So people get an orbital floor fracture and the inferior rectus on that side gets damaged or trapped, and maybe doesn't work even if it's repaired. And now the eye doesn't go down the way it should, but the other eye is going down normally, and they get these big hypertropias and down gaze. Well, if you do a Faden on the normal eye and limit the inferior rectus on that side, now both eyes don't go down as well, and you'll get a greater range of diplopia-free balancing. It's not perfect, but it helps a little bit. And then the final topic is how do you do a modified Nishida procedure? So transpositions, 6 nerve palsies, monocular elevation deficiencies, 3rd nerve palsies, sometimes Duane syndrome, all these instances when we're doing transposition procedures. There are lots of different transposition procedures. I've had a long time preference for doing full tendon width transpositions, frequently adding a Foster augmentation suture, which is almost like a Foster, or almost like a Faden suture and how it's applied. You can do partial thickness transpositions, you can do Jensen's, Helmelstein's, all these things. The Nishida is just another version of that, where it was originally described to split, say for 6 nerve palsy, splitting the superior rectus and inferior rectus, and then transposing the halves with just a suture bite through them, transposing them down by the lateral rectus. And then over time, the modified Nishida was described, which is what is illustrated here. And what happens is you have a non-absorbable suture, whether it's a nylon or Merceline or Proline, and you're taking a bite through the border of the superior and inferior rectus, maybe getting about 1/3 of the muscle width. And then you are in this quadrant, and that goes about 9 or 10 millimeters back from the insertion. And then in the quadrant between the muscles, in the direction you're trying to augment the lateral rectus function, say for a sixth nerve palsy, in that quadrant, you're measuring back about 12 millimeters, and you're just partial thickness scleral bite there, and then you tie that, and um, I just rolled out of my chair here for a second. Let me go back. Yeah. So then you tie that, and it drags the superior rectus and inferior rectus there temporally, so that you're getting some lateral force vector out of it. And why do we do this rather than some of the other techniques? Well, it's vessel sparing. So essentially, if you have some concerns about anterior segment ischemia, this is one way to limit vascular disruption. Now, I've only recently started doing these, and so I don't have a great feel yet for how it compares to my results with full tendon transposition. I'd expect it to be a little less powerful, but we'll see. But it's a nice option, and that's how you do a modified Nishida procedure. Here's a question. It's regarding patients with restrictive strabismus, especially a chronic sixth nerve palsy. So even after doing large recessions with transposition, they still have residual ET with positive traction testing. Yeah, what should I do? This is always tough. So they're describing someone who has a sixth nerve palsy. You've done a transposition and of the superior and inferior, and you've done a medial rectus recession, and they're still restricted. And they have a positive force duction test. Well, there are only so many things you can do here. Once the transposition is kind of an all or none, so then the only things you have remaining are to loosen that medial rectus. So if it's been recessed, you can re-recess it if possible. You could Botox the medial rectus, and you can go to the contralateral medial rectus and recess it and try and get some effect. But, practically, sometimes you just can't get all the correction that you need. But if there's a restriction, whether it's thyroid or this case with the sixth nerve palsy, if there's restriction, the answer is alleviate the restriction if possible. So more recession of the medial. Question about your approach to DVD surgery. So DVD, like I said, 90% of kids with congenital ET get DVD. You have options of, if there's inferior oblique overaction with the DVD, I will do anterior transposition of the inferior oblique. All right, that's probably my preferred procedure. If there is not inferior oblique overaction with DVD, I will do large recessions of the superior rectus. So if it's bilateral, we're talking 8 millimeters. If it's unilateral or asymmetric, we're talking 5 to 8 millimeter superior rectus recessions. The third option, which is probably the least commonly performed, is you can treat DVD with inferior rectus resections or plications. And at various times in history, that's been more and less popular, but it's definitely the procedure that I do the least often. So preferably inferior oblique anterior transpositions. All right. Next question regarding children with a large angle ET, 60 prism diopters or more. I usually perform 3 muscle surgery to address the whole deviation. It sounds like there's so large angle ET, doing 3 muscle surgery in 1 or 2 cases. The patient turned out to be exotropic at distance. What should I do when they're inattentive? Well, typically, if someone gets an overcorrection from, whether it's from this or just regular esotropia surgery, how do you approach overcorrections from esotropia surgery? I think that's a good question. If there is any evidence that the motility is not normal, that could be evidence that the resection is too tight, they're restricted, or it's evidence that the medial rectus is too weak, that it's slipped. And so if I see that there's an adduction deficit, I will traction test the lateral rectus to see if I think it feels tight. If it is, I'll recess it. If there's no restriction though, but there's an adduction deficit, then you need to explore the medial rectus and advance it and resect it. You'll usually find that it's slipped and there's going to be a section of anywhere from 3 to 7 or 10 millimeters of attenuated muscle where it has slipped back within the muscle capsule. It's not stayed sutured. And so in those cases, you just need to resect that attenuated section and decide if you just put it back in the same spot or you're going to advance it some. Question regarding pediatric uveitis with cataract. How is it managed? This is always a difficult thing because you don't want to do cataract surgery in a hot eye. So if you have active uveitis, or you've had active uveitis, you don't want to do anything right away. You want that eye to be quiet for at least 6 months. And so whatever has to be done in terms of steroid-sparing medications like methotrexate, some of the other agents, steroids, you want that eye to be quiet before you do cataract surgery, particularly if you're doing a lens implant. If you put a lens implant in a hot eye, you are asking for a disaster. If you really have to do cataract surgery in a patient with recent or active uveitis, I would leave them aphakic, and I would do a secondary lens once the eye is settled down. All right. Question about how the intraocular pressure changes in children. What's the normal level for neonates, infants, toddlers, teens? And when do you consider the IOP is raised for a particular age group? This is a question that really has no answer because we don't want to fixate too much on the intraocular pressure, even though there are some normals. Again, if you go to the pediatric ophthalmology course, there's a whole section on pediatric glaucoma. In general, though, the intraocular pressure in a neonate is going to be lower, so low to mid-teens. You can have a kid with congenital glaucoma that clearly has changes to the structure of the eye, and the pressure might be 20, but they still need surgery. Whereas in an older child or a teenager, the pressure is going to be more what we think of in adults, where normal is more like 15 to 22. So don't fixate on the pressure so much as comparing the right and left eye. If there's a difference, that's a sign that the pressure is too high. Or if there are structural changes in the eye, those are things that you really need to pay attention to. Next question, which I'm surprised we didn't talk about this, but question about Botox. Indications for botulinum toxin injection in strabismus. Some people use Botox for a lot of things and in place of surgery. For me, the role for Botox is typically going to be acute 6 nerve palsies. If I have someone who has a large 6 nerve palsy and it's been there for a couple months and we're going to wait 6 months or so to see if it resolves before surgery, I will use Botox to keep that medial rectus from getting restricted. And I'll usually be doing these injections at 2 to 3 months into their acute palsy. So you don't want to do it right away because so many of these are gone by 6 weeks. But if it's persisting in 2 or 3 months, that's a good role for Botox. I'll usually put about 5, sometimes 10 units in the medial rectus. And you can do that in the office, or you can do it with sedation in the operating room. I've kind of developed a preference for doing it in the operating room, but whatever you're comfortable with. Rarely do I use it in long-lasting strabismus, although one could make an argument for doing a medial rectus injection in a chronic 6 nerve palsy to try and loosen that muscle before doing a transposition or other procedure. But I think from a practical standpoint, I usually just go straight to surgery if it's been chronic. Question about how do you measure angle for surgery in a partially accommodative esotropia? And we touched on this, but if you have a partially accommodative esotropia and you are measuring for surgery, then I treat these like a fully accommodative esotropia. I'm measuring their deviation with the glasses on, and I'm operating for the residual deviation. I would not try to correct what they look like without the glasses, all right? Because a 5-year-old with hyperopia is going to start to lose that hyperopia after 8 years of age, and you'll create a consecutive exodeviation, all right? So operate for what they look like in the glasses. Here's another question. In case of consecutive exotropia in patients with hypertropia, for example, +4, should we prescribe glasses before surgery, even though the exotropia increases with correction? Well, if you've done surgery and they've developed a consecutive exodeviation, you don't necessarily want to give them the full plus. And here's where you can play with decreasing the plus. So this is similar to over minusing, right? So you give less plus or you give someone more minus. If someone's a +4 and they've got a consecutive exodeviation after surgery, put trial lenses in front of them, see what they look like with a -1 or a -2 or a -3. And if they look better, then reduce their hyperopic correction and try and play games with that accommodative convergence response. And some people will tolerate that and some won't. And sometimes you just got to go back to surgery, but a lot of times you can get away with reducing the plus. Next question, 6-year-old child with 6/6 vision, both eyes, so normal vision. Cycloplegic refraction is +175, but they have a manifest exotropia of 30 prism diopters. All right, so in a 6-year-old, a refraction of a +175, I would just say that's normal and not a factor. So if I would not put them in glasses, and if they had a manifest 30 XT, I would operate for 30 manifest XT, and the optical question is just not a factor. What is your preferred incision location for strabismus surgery? Well, there's not a set answer here. What do I prefer in, I think, so there's a fornix incision and a limbal incision. The fornix incision, I think, has the advantage of it heals with less scarring, it heals more predictably. I think patients are more comfortable. Sometimes it doesn't require suture. But you need to have healthy conjunctiva to do a fornix incision. And so for me, it's usually kids and young adults up to middle age for primary surgery. For a primary surgery or a repeat surgery in an older adult, the conjunctiva is very thin. You can't stretch it like that. You'll just tear it. So for adults that are middle-aged and older, I'm usually doing limbal incisions. Now, I will also do limbal incisions for reoperations on children, especially if I didn't do the primary surgery and I'm not sure what to expect. I find that having that better exposure is helpful. Limbal incision, because it does have better exposure, it's generally easier to do and easier to see what's going on. So for less experienced surgeons, or if I'm teaching, sometimes that's preferable. But I think they both have a role. I don't think one's better than the other than I have a preference for the younger kids and fornix incisions. MRI, do you do an MRI in superior oblique palsy? Not normally, but I think the question is here, as you see the patients, are there suggestions that it's an intracranial process, as in, is the superior oblique palsy new or not? Most of these patients with superior oblique palsies that we see, they're decompensated congenital palsies. And you can look at the patients and they've got facial asymmetry, or you look at their driver's license or old photographs and they've got a head tilt from 10 years ago, and you measure their torsion and it's 5 degrees excyclotorsion or less. Those patients probably don't need neuroimaging. They've got congenital decompensated palsies. But if someone's got a brand new palsy and they don't have facial asymmetry and there's no history of trauma and they've got small vertical fusion amplitudes and a lot of torsion, well, in that case, yeah, now you've got something that looks like it's an acquired palsy. You want to be able to explain why that is. So that's when I might do an MRI. This question is about bifocals for accommodative esotropia, which are ortho with distance glasses, but near esotropia. So patient has refractive esotropia, they're ortho at distance, but residual ET at near. This question says, some reports say there's no significant benefit to bifocals versus no bifocals over time. What I have seen is that if you have a patient, let's say they're 5 years old and they have a high ACA ratio and distance is ortho, and then I put them in bifocals and I can kind of control their near deviation. A lot of those patients successfully outgrow the strabismus and don't need surgery. So, you know, is there statistical significance to it? I don't know. I guess I haven't seen those studies. But from a practical standpoint, yeah, there are many patients that you can nurse along during that young age with bifocals. And then as their hyperopia and their accommodative convergence naturally decrease after age 8, you get them out of the bifocals and they avoid surgery. So I try them, and when they work, they seem to work quite well. If they don't work, then we go on to surgery. When do you use a microscope during strabismus surgery? Never. I find that it's in the way. Obviously, you have great magnification, and but you have a small field of view, and now you have something that's in the way when you're passing instruments back and forth. I really dislike the microscope for strabismus surgery. I think you're much better off having surgical loupes, and there are inexpensive loupes out there. You know, $400 you can get a pair of loupes. What are you looking for in loupes? You're looking for about a 2.5x magnification. That's a good compromise of magnification and field of view. And you're looking for a long working distance. So 16, 18 inches, I think that's preferable. Question about patching for intermittent strabismus to improve control. I have tried this over the years for intermittent exotropia, and I have reached the conclusion that it doesn't really make any difference. And other people are going to have different opinions, but to me, this is just something that people do to buy time, and it doesn't really impact the outcome of the strabismus. So, not a big fan of part-time occlusion for exotropia in the absence of amblyopia. Well, we're an hour and 15 minutes into things. I think I am going to bring this to a close. And as always, it's a pleasure. I enjoy these question and answer sessions. And thank you to those 93 people who sent questions in advance. Very much appreciated. So thank you, and good luck out there. Let us know if you have any questions. Thank you.